Welcome to Effective Teamwork in Healthcare. Thank you to all of the participants who are joining us from more than 75 countries around the world. This webinar is brought to you by Harvard Online. We're proud to share that one of our panelists today, Michaela Kerrissey, was recently named by Thinkers 50 as one of the 30 up-and-coming thinkers whose ideas will make an important impact on management thinking in the future. Congratulations, Michaela. We're also excited to share that Amy Edmondson's new book is coming out next month. It's called Right Kind of Wrong, The Science of Failing Well. We'd like to start by asking you, what has been the most successful failure in your career? You can sit with that question, or you can share a note in the chat. But before we get started, we'll run through a few housekeeping items. All participants will stay muted, and the chat function will be turned off for the duration of the event. We will be answering questions intermittently throughout the webinar. While we'll do our best to answer as many questions as possible, we will not be able to answer all the questions. We encourage you to share your questions in the Q&A function at the bottom of your screen. There, you can submit your questions and view questions from other participants. You can also upvote questions that resonate with you. At the end of this presentation, we will share a discount code and link to Amy and Michaela's new course, Innovations in Teamwork for Healthcare. We're excited to introduce to you our moderator and panelists for this event, Amy Edmondson, Michaela Kerrissey, and Derrick Bransby. Without further ado, let's begin. Derrick, the virtual floor is yours.
Thank you, Elaine, and to our entire team behind the scenes. And again, welcome to our webinar. My name is Derrick Bransby, and I'm a third-year doctoral student at Harvard Business School, where I study how individuals, groups, and organizations learn to collaborate, innovate, and perform. I'm also your moderator this morning, afternoon, or evening, wherever you may be. We are thrilled to have participants from over 75 countries with us today. We're joined this afternoon by two amazing panelists who I'm honored to call colleagues and mentors, Amy Edmondson and Michaela Kerrissey. Amy is the Novartis Professor of Leadership and Management at Harvard Business School. She has pioneered the concept of psychological safety for over 20 years and is the author of Teaming, The Fearless Organization, and her latest book, The Right Kind of Wrong, The Science of Failing Well, out next week on September 5th. Michaela is an assistant professor of management at the Harvard T.H. Chan School of Public Health. She researches how teams and organizations innovate, integrate, and perform with a focus on healthcare. Michaela has authored over 30 publications on these topics and designed the Organization Science for a New Era course at Harvard School of Public Health. Michaela and Amy, thank you for joining us, and we're delighted to have you today. Our time together is split into two parts. First, we'll discuss the challenges facing healthcare teams. Then in part two, we'll discuss teaming and how it might help us address these challenges. Both discussions will be followed by an opportunity for questions from the audience. Audience members, if you haven't already submitted your questions for Amy and Michaela, you can do so at any time using the Q&A function in our Zoom app. So let's get started. Michaela, let's start with you telling us a little bit about some of your earliest experiences in healthcare and the challenges facing healthcare teams today.
Sure, thanks, Derrick. I started out in HIV/AIDS services, and I think my story is probably not all that unique for people that wind up in healthcare. I liked science, and I wanted to do something meaningful and improve human health. And then I realized on basically day one that there are two parts to that equation and pulling that off. Right? One is the one you expect. It's the technical expertise. So whatever it is, if you're a clinician, it's the clinical medicine. If you're in population health, maybe it's statistics, you name it, it's a technical field. But it's mastering that expertise domain. And you know that kind of going in, right? And then you kind of get blindsided by this other side of it. And that's when you realize that it's not just the technical expertise that you bring, but it's the teamwork across the technical expertise that really makes it happen. And the problem that I saw then and have basically spent the last 20 years working on is that in medicine, we do so much around that first issue, the technical training. There's so much training and credentialing, and even the on-the-job training is pretty good. And then on this second piece that basically, I imagine I'm not alone, and who's ever on the line here who has worked in healthcare delivery for more than a minute probably knows this very well. This second part about how do you do the teaming, we get almost nothing, no training around, not a lot of support around. And that's a really important gap. Because we see so early on that it really matters. So that's what I have been focused on, really because I think that people who work in healthcare deserve better, and patients too.
I know that's a story that resonates with me, and I'm sure many others with us. Amy, you wrote the book on teaming and have studied healthcare settings extensively in your work over the years. Can you tell us about how the challenges Michaela just described fit into a larger picture of how teamwork is different in healthcare than it is in other settings?
Absolutely. Thank you. Yeah, so unlike the two of you, my early work in healthcare was as a researcher. I was a researcher in the field of organizational behavior, rather than as one of the people actually working in the space. And so I was quite surprised to discover, probably almost as quickly as Michaela discovered it, how complex were the sort of managerial and organizational sides to healthcare. Again, all of you, I'm sure, joining us today know this very well. But part of my early study was to study teams. That wasn't so easy. Where are the teams? And I'd ask people, tell me about your team. And they would say, well, which team? My rotation team, my unit team. And I began to realize that people weren't on stable, formal teams. They were teaming. They were working in different teams at different times of the day based on the work they had to do. So what I learned in healthcare was that this was a kind of a bellwether, or maybe an extreme form of what other organizations were facing, where teamwork was getting more and more complicated, largely because the uncertainty was high. Now, anytime uncertainty is high, whether due to the need for patient customization, because of the inherent task variability or other factors, people need to team up with each other to do the work, but without the luxury of stable, well-bounded, well-practiced teams. So they do sort of teamwork on the fly, if you will. They must learn as they go from each other, from what happens, and make adjustments along the way. It's also, of course, as a 24 in the hospital setting, at least, a 24/7 operations compound the problem. So being on a stable team, I learned, is not the reality for most people in healthcare. By the way, I think it's no longer the reality for people in most business organizations either. But through the best practices for fluid teaming, which our course is really about and which we'll talk more about today, people can achieve the benefits of teamwork even without the luxury of stable teams.
It's a great segue to our next question for Michaela, who recently wrote a wonderful article aptly titled The Ambiguity of We. And in this article, Michaela, you found that there was substantial variation in how primary care teams composed of clinicians and staff defined their team. What do your findings tell us about the challenges that healthcare teams face?
Well, it's interesting in listening to what Amy was just saying. In many ways, the first big insight of that paper is putting some numbers and some real evidence to this point that Amy just made, observing it when you first went in to do research on healthcare teams, which is that the degree of instability in the teams is so high. And what we found, even in primary care environments, where it's probably a bit more stable than it is in some other more acute healthcare environments, even in that environment, we saw a lot of fluidity or shifting team membership and how people described their teams. And what was so striking about the findings from that study was that the way people saw their teams varied dramatically in such a messy teamwork context. So you take two doctors practicing in the same primary care clinic, And one doctor, if you asked who's on your care team day in and day out, they might list 2 other roles that they work with. And then the doctor with their office just down the hall would list 15 different roles. And the implication, the first point of that paper, that it's a bit of a wonky point, but it really matters because it's a measurement problem, but it's also a meaning problem. If we don't know who we're talking about and what we're talking about when we talk about teamwork, it's really hard to improve it and make it better because we're all talking about different things. So one point there is just this real need to get much sharper in how we talk about teamwork and how we measure it. There's a lot of money and time spent, at least in the US, and those of you from other countries can tell me what it's like in your countries. But in the US, almost every single medical group and hospital in the country is collecting data about teams. And our study would suggest that when people fill out those questions on surveys, they're actually talking about very different things. And so I think that's exciting because in the next 10 years, we are going to get a lot better and sharper about how we do that. The second point that I think is really interesting from that study is much more of an implication. So we looked at the size of teams that people perceive and their experience and work quality. And what we found was people who perceived more other people that they worked with day in and day out, they had better care quality. They were delivering better care quality day in and day out. But if you looked at what it was like for them, the people who were doing the most collaborating, for them, it got better to a point, and then it actually turns negative. Meaning for those people that are doing the hard work to do teaming as much as they can, it's helping them do the job, but it's in some way exhausting for them. Or maybe even ironically, like lonely, right? You spend so much time teaming up with other people, and at the end of the day, you feel alone in it. And the practical implication there is that for teaming well, people need tools and resources to actually do it well so that it doesn't burn them out. And we know there's this huge epidemic of burnout right now. And if we don't do better at helping people manage this complex teaming environment, it's a disservice to them. And so I think that paper is really a clarion call to do better in helping people team up well. And for me, at least, I think part of the impetus for doing a course like this to actually try to put some tools and perspectives in people's pockets to make it better.
Thank you, Michaela. And all of you on the call, I recommend that you check out this paper. It's called The Ambiguity of We in Social Science and Medicine. It is a great paper. My plug for Michaela. Perhaps another way that healthcare differs from other industries is our ability to fail and learn from failure. And Amy, this is the topic of your latest book, The Right Kind of Wrong, The Science of Failing Well, where you explore how we fail productively in healthcare and outside of healthcare. So in a field where failure can lead to life-altering consequences, life or death, how can we differentiate between good and bad failures in such a setting?
Thanks, Derrick. You know, you might think I'm stretching it, but I actually do see a really nice segue from Michaela's, and I agree, just totally creative and fascinating paper, because I think the people who would report greater numbers of, teammates were more probably, inherently more aware of their interdependence, which is exhausting, but it is also such an important attribute for preventing the kinds of failures that didn't have to happen. When you're a natural systems thinker, or when you're just seeing a little farther beyond your immediate task, you're going to be better positioned to prevent failure. So, the key here, I want to just make absolutely crystal clear to everybody that I would never advocate for failures where success was a realistic, feasible option. In other words, let's get success in all those instances where it's possible, where we know how, where we have a formula or best practices. Let's use them. I'll come back to that. But the good kind of failure, the right kind of wrong, if you will, and I call these intelligent failures, are those that take place in new territory in pursuit of a valued goal, informed by a hypothesis. In other words, you have a reasonable belief that it could work. And they are, and this is really important, especially in healthcare, as small and safe as possible to allow the learning. So they are literally the source of new knowledge. And in every field, from science to sports, intelligent failures are where progress comes from. And strictly speaking, intelligent failures, you might be thinking of them as just the sort of undesired result of an experiment, and you'd be right. Intelligent failures are not preventable, right? They can't be prevented because nobody yet knows what will work, so they are good, but we don't do them, while we're flying the plane. We do them in the simulator. In healthcare, same thing. Simulation is a great place, or laboratory science, a great place to advance knowledge through intelligent failures. Now, the bad failures, I think of them as in two categories. One is the single cause failures that are generally caused by human error. And those, of course, in healthcare especially, we want to minimize those to essentially zero. We want to work really hard, not to prevent human error, because that will always be with us, but to prevent and interrupt the error before it causes a failure. There's also, and you all know this well, the multi-causal failures, which I call complex failures. These are what James Reason would describe as the Swiss cheese of failures. They're where a number of factors come together at just the wrong way, at just the wrong time, and lead to a mishap in relatively familiar territory. Both types, basic failures and complex failures, are preventable with vigilance, with teamwork, with psychological safety and speaking up, and of course, as much error proofing as possible, including such things as consistent and highly visible labeling for medications and all the rest. But all kinds of failure, the intelligent and the basic and the complex, can and must be learned from. And that, again, is where progress comes from. And I think an essential strategy, as I said, for effective learning from failure in healthcare is the use of simulation, to practice new tasks, to practice teamwork even, and any challenging activity. It's better to do it in a very safe place where no one can get hurt first. And just as they do in aviation when the stakes are, of course, so very high.
Wonderful. Now let's turn to some questions from the audience. Our first question is from Patrice and Sarah, and they ask, with the rise of telemedicine, how do you continue to encourage teamwork and engagement in a remote setting? And Amy, I know this was the topic of a recent interview, maybe that you gave. Could you maybe start us off on this question?
Yeah, first of all, I think it's a wonderful question, and I think it's a work in progress. I think we are continuing to learn what works, but my starting point is to make it explicit that it's relatively new territory or quasi new territory, and so invite people, invite people to help co-create what is going to work, and engage people explicitly and deliberately to make sure that we are hearing from the different perspectives that we need to make progress, make sure people are engaged and the team is getting the benefit of the expertise that's present.
Michaela,
I'll add one piece to that, because I do agree this is rapidly evolving, right? There is no playbook that we know exactly how to do this one right yet. But I think one of the areas that really matters here in terms of teamwork, when you have providers working remotely and spending most of their days remote, is that this issue of sharing information and doing the behaviors of teamwork that we'll talk a lot about in this course, psychological safety, joint problem solving, these behaviors that we have been studying and know matter in team contexts, I suspect are more challenging to get right when it's fully mediated by an online environment, and it requires being even more deliberate about helping people to speak up, asking questions, because you just can't assume. You don't know if you're having a hard conversation with somebody and their camera goes off. you don't know if it's because their kids, as often happens to me, are running around in the background, or if you've said something that really upsets them, right? You don't know the reasons behind why people are doing things and feeling things in the way that we often intuit better in a room. And so the bar is a lot higher for getting the interpersonal teamwork stuff right. I think we will have to be even more expert in this online world.
Yeah, that's a great point. Our next question is, can you speak to the impact of patient safety incidents and medical errors on psychological safety and teaming?
Sure, I'd love to start on that one. It's okay. And the first thing I think is really important to understand is that it's not just a direct cause effect, incident impact on psychological safety. It's entirely determined by how the incident is handled, managed, talked about, framed, especially by people in positions of leadership or authority. And this is just so important because the way we understand the events in our lives, including our work lives, is very much mediated by the frames that those in our surrounding, and especially those with power, bring to the incident. So if an incident happens and it is framed as obviously upsetting and important for us to quickly learn as much as can happen, and we step back and we do the whole multi-perspective diagnosis to understand that all-important question, which is what happened, not who did it, not who screwed up or what went wrong, but what happened. And more often than not, that multi-causal, multi-perspective learning process is very productive and very insightful for people, right? They learn something from it that is entirely about how do we prevent this from ever happening again, right? So a short way to say this, I suppose, is when it is framed as a very upsetting but rich opportunity for learning, then psychological safety not only doesn't get reduced, it grows because we're doing the hard work of learning despite the sadness and frustration of an incident happening.
Our next question is from Jeremy, and it's one that I know has caught my attention recently. And he writes, healthcare may be one of the only industries that does not integrate R&D into new knowledge, the place where small, safe errors can be studied even more safely within a system to allow for system learning. How do we integrate this research and development mindset into healthcare with teaming as a component of the major function?
Michaela, I think that sort of sounds like joint problem-solving orientation, but maybe I'm overstating it.
So I think at its core, this is a question about innovation and learning in health systems, right? How do we actually do it when we know that you have to do both the big learning, right? Like capital L learning, R&D, and you have to do the little learning, which is the micro quality improvement work, process improvement work that people like that Institute for Healthcare Improvement have made so famous and so accessible. And so, Amy, you bring up joint problem solving, right, as a way, to do this, because whenever we want to be able to innovate, to make new things happen, whether it's the small learning or the large learning, it's going to rely on bringing people together from different areas of the organization, different expertise areas to do it. And so one of the challenges when we put together these improvement processes, whether it's R&D or sort of quality improvement, is we can reinforce silos instead of breaking them down in how we set up the problem solving. So one, I can give you an example just really briefly. It comes from a case I just wrote with an old friend of mine from when I was in grad school, and he's a physician. He's an ED physician now in California. And he works at the Zuckerberg Hospital. And we wrote this case because, in part, the Zuckerberg Hospital is named after one of the most famous tech entrepreneurs in the world. And yet at that hospital, they, like many hospitals in America, were still using pagers to page people. And he led an effort with some of his fellow ED physicians to stop using pagers and to use a smart device. And it failed. And one of the reasons why it failed is when they put the improvement process together, they kept it all within the ED. And so they solved it for the ED, but the consulting physicians that they had to rely on to use that didn't want to use it, and they didn't team up to do it. And so part of this is not just about the process for improvement or even the R&D process, but how do we bring the right people to bear in the right way so that they can do it together so that the solution will work in this kind of complex system. So Jeremy, your question is near and dear to my heart. I think it's high time that these worlds of kind of systems thinking, teaming, and innovation all come together more meaningfully.
I completely agree, and I hope it's something that we will learn more about in the coming years. So let's move on. Now we've talked extensively about the challenges that we face teaming in healthcare to what can we do about them. And to do that, we'll turn to a concrete example of teaming in healthcare that's featured in our course. Michaela, you've studied the Cleveland Clinic. Could you tell us a little bit about the hospital and the teamwork challenges it faces?
So the Cleveland Clinic is a premier global healthcare delivery organization with an increasingly global footprint. They are expanding, and like much of the activity that we see, at least in the United States, consolidating quickly and growing both vertically with incorporating new types of providers and horizontally and spreading into new geographies. And they are famous for pioneering the group-based model of care initially about 100 years ago now. And they have ever since then taken teamwork really seriously. Everyone in their top leadership will talk about it and talk about what they're doing about it. And so that makes it a really fascinating place to learn from when we think about making teamwork happen in healthcare, because we know these really large, complex organizations are the wave of the future, right? This is how a lot of healthcare is going to get delivered. And it's one thing to make teamwork happen if you're running, say, a small practice or an organization with 10 people. If you're like the Cleveland Clinic and you have, I think there are over 70,000 employees globally now, how do you make teamwork happen in that environment is really one of the biggest questions that healthcare delivery organizations face. So we have been learning actively from the Cleveland Clinic about how do they manage it and how do they think about it.
And in your time at Cleveland Clinic, you've had the opportunity to speak with the CEO, Tom Mahalovic, and Chief Caregiver Officer, Kelly Hancock, about teaming. And they describe a strategy that they use called the tiered daily huddles. Let's take a look at a quick video.
Tiered daily huddles are an instrument for 22,000 caregivers that participate in the care of patients in Cleveland every single day to focus on what matters most for their patients and to solve the problems that they can solve at their local levels. And for problems that they cannot solve on the local level, they can be elevated all the way up to the executive team so they can be addressed right that very day. And just to describe it briefly, caregiver teams go through a structured 15 minutes meeting where they speak about quality, safety, experience of care that they're providing, expectations for that day, an environment of care in which they work, and any issues that are associated with any of those aspects of care that they provide.
So the first tier is really every morning at 7:30, whether it's a nursing unit or it's at a clinic or in an OR or wherever the business is taking place. And then you manage that information up. You manage it up through the 6 tiers, which the 6th tier is 11 o'clock every day with the entire executive team, including our CEO. And it's amazing. In a matter of 15 minutes, a report is generated about, did we have a near miss? Did we have a serious safety event that needs to be examined further? Did we harm a patient? We conclude the Tier 6 huddle every day by remembering those patients that we served who expired in the last 24 hours, and we do a pause. So at the very end, whoever is reporting out will say, in the last 24 hours, we remember 25 patients who expired under our care. And they just name their first names. And at the conclusion of that, as an executive team, we pause for a moment and remember those patients because it keeps us grounded in our work. To me, that's very powerful.
Michaela, in this video, we get a glimpse into the tiered daily huddle. And one facet of the daily huddle is something that you have studied extensively called the joint problem-solving orientation. Can you tell us what that is and describe a little bit of the research that you've done about it?
Sure. So, and I'll explain joint problem solving first, and then I'll touch it on why what Cleveland Clinic is doing with those tiered huddles is such an interesting and important way of going about joint problem solving orientation. So joint problem solving orientation, it's essentially about how much of a we mindset there is on teams when problems arise. So does a team member see other team members, their own problems as shared across them? When an issue comes up, do they actually try to work together to do something about it? Or is it kind of more, I've got my issues, you've got your issues, and maybe we negotiate it a little bit, but you are on your own at the end of the day? Essentially, do they win and lose and learn together? Right? That is what the joint problem solving orientation is really about. And it may seem obvious, but in this case, obvious is good, right? Because it means that it reflects something that is a really true part about what it is like to try to make progress in these environments where teamwork is messy and fluid, and you're bringing people together across different backgrounds to try to do it. And you might not have control, for example, over whether Sue and Bob actually show up to your meeting. They can just stop showing up. In those environments, this kind of shared responsibility for problems and for co-creating solutions is important, and it gives people something that they can do in these environments to try to make it better. You can try to establish joint problem solving orientation actively. And that's what I was so interested in the tiered huddles for Cleveland Clinic, why it really caught my attention, because that daily huddle process, yes, it's about identifying the problems that haven't been yet resolved. And yes, it's about ensuring that they have their eye on important issues. But it's also about creating an environment where that kind of joint problem solving orientation is emphasized, appreciated, and prioritized about how work is going to get done. Because you may be in a floor in a hospital, say in Florida, and you know that if you have an issue in the morning that is not resolvable by you, if it continues to not get resolved, it will wind up on the desk of the CEO, and they are going to sit and try to solve it with you. And so in that respect, it's an interesting example of the role of leadership in establishing something like joint problem solving orientation. And then we've studied it across teams within the Cleveland Clinic. And what we find is that for the teams that are able to instill that more, so it's about that top level leadership establishing it, but even at the department level, where you're seeing departments where people are able to establish this more strongly, the performance in that department tends to be higher. So it's this cascading of values around shared emphasis on problems and shared emphasis on solving them together that you can, even in these really massive organizations, try to distribute throughout the entire organization. I think they would say it's still a journey for them from 100 years ago with a group-based care model to today, but it's an example of working hard on it and taking it seriously.
Amy, you've spoken before about the hardware and software of teaming, and joint problem solving orientation is part of that software that you talk about. Could you expand on how we can think about the tiered daily huddle in those terms of the hardware and software of teaming?
Sure. So I think of the tiered daily huddle as a scaffolding for teaming and learning, right? It's in a way, it's the structure, right? The scheduled structure of it, this tiered structure is a kind of hardware. It's baked in to the system. This is what you will do, right? You will do this from 7:15 to 7:30, and someone else will be doing it from 7:30 to 7:45. And, within a pretty short time, all of the important learning of the day or yesterday has gotten all the way to the executive leadership team, right? Which is a pretty interesting design for ensuring that the organization keeps learning from its own experiences and does that through teaming, right? Does that through sharing what we know that's relevant quickly, efficiently, right? You get the quick impression, and you'd be right that this is efficient, right? It's a kind of an efficient structure. The software is, yes, joint problem solving orientation, which is a mindset that we share this, we own it, we co-produce the solutions that work. Another absolutely vital aspect of the software is psychological safety. I define psychological safety as a shared belief that my team is safe for interpersonal risks, like admitting an error, speaking up with a question when you don't know how to do something, offering a dissenting point of view. All of those inherently risky interpersonal behaviors feel more feasible in a psychologically safe environment. And so that's a crucial part of the software of effective teaming, where the quality of the data, the quality of the conversation is high. It still can be very efficient, but it's oriented toward learning.
We have just a few minutes left before we get to our next question and answer portion. So I have two more questions for rapid fire, one for each of you. Michaela, if there's a theme that has become apparent in our conversation over the last 37 minutes, it's that teaming just doesn't happen on its own. Can you tell us a little bit about what we need to know about leading teamwork in healthcare?
Well, it's funny in that in the way we've been talking, that teaming does happen. Teaming is going to happen. It's all around us, right? Whether we like it or not. And I think what you're saying, which is absolutely dead on, is that if we leave teaming to chance in how we do it, we will likely be disappointed. I often ask when I teach in person, I ask people, okay, how many teams are you on? And people start tossing out numbers. In healthcare, people will say anything like 1, 5. I almost never get 1, 5, 10, and usually somebody kind of like throws up their hand and says, "Oh gosh, don't even get me started." And of course, it's like an entrance. Then we get started, and I love to ask them to actually sometimes I have them draw it out. I say, take out a white piece of paper and draw it out in front of you. What does your teamwork look like? And people make these kind of spaghetti soup diagrams of what their teamwork looks like. One day, I think I'll put them in like an art installation somewhere. They're a great representation of just how messy and really also how much great work is going on, because all of that teaming, it's a headache to manage, but it's getting something done that's really important. And so I think in terms of what matters for leading teamwork, the first thing that really matters is about taking that messy environment seriously and not wishing it away and just hoping, taking your org chart that has these clean boxes and lines and hierarchies and pretending like that's all that's going on. So leading teamwork is about really, in a teaming environment, is about taking it seriously and starting to learn about how you can do it better. And to learn not just alone about teaming, right, but together with the people that you're teaming up with. How can we do this better? I like to talk about, for those healthcare improvement people out there, I like to talk about it as sort of starting to think PDSA style, plan, do, study, act style, but for teamwork, right? Making micro level improvements, seeing, can we change this and make it better? So that's the first one, learning about teamwork. And then the second one, the second real piece to think about is that teaming and leading teaming in this environment with those messy diagrams that people draw out, it's everybody's job. The days where we could kind of hope that our boss establishes it and then wait for it to happen are really gone. It matters what top level leadership are doing, but it's also for all people that are engaging in teaming, it's about leadership as a set of behaviors that you do that can make teaming really thrive. And that means that this is really for everybody to be thinking about from day one.
Amy, last question for you. All of these efforts toward teaming require an investment of time, of energy, of money, perhaps. What are the outcomes of teaming that make all of this investment worth it?
The outcomes. Well, to me, it's twofold, right? One is the quality of the care, or the quality of the work, the quality of the innovation. Right? So teaming's outputs are what really matter. You have integrated diverse perspectives into a product or service that adds value. And yet there's this dividend, right? The other absolutely crucial outcome is your own and your team's learning. I like to say, you go to school every day in the team. The team is both the unit of the work, but it is also the source and the context of your learning. And so a good day at work is one in which you felt you and your team did good work, but you also came away just a little bit wiser, a little bit more knowledgeable, a little bit more able to contribute in the future.
So we'll turn to questions now. I love this first one as I interact with a fair share of medical students myself. The question is, as medical students, how can we have effective teamwork despite the hierarchical relationships we have in our groups?
So can I take that one?
Yes.
So, to me, hierarchy is not the problem. It's how hierarchy is handled that really matters. And I did one study with the amazing Ingrid Nemhard, a former student and colleague, and we showed that teams with identical hierarchy on paper had very, very different outcomes, essentially based on the degree of psychological safety in the teams. Hierarchy didn't go away, but the way people interacted with hierarchy really mattered. Ultimately, the aspect of how hierarchy matters is when people who show up, great clinicians do this spontaneously, really, but they show up with curiosity. They make explicit the invitation that they need and want to hear from others. They listen to what they're hearing. They teach, they engage. And so hierarchy can be a fine organizing principle. It's only in a way when hierarchy is sort of badly used that people are less able to engage in effective teaming.
And I'll add to that it's spot on. And this paper that Amy was mentioning, that with Ingrid Nemhard about psychological safety and hierarchy in teams, it was one of the papers that really caught my interest in getting into this area, for thinking differently about how we can work in healthcare to generate more psychological safety when the hierarchy is not likely to ever disappear entirely, and for good reasons, right? There's expertise and experience that really matters here. And one of the questions that we get asked then a lot is, well, if I'm a medical student and the people who are higher in the hierarchy than I am are not creating these conditions of curiosity, what do I do? And in some ways, there are aspects, if you're working in a department, say, and the chair is not doing it, you don't have control of that over that as a medical student. But The reality is, when we look closely at healthcare environments, it's not that there is this one hierarchy that everybody sticks to and it never changes throughout the day. In the course of all of our days, where we are in the hierarchy often shifts depending on the interaction that we're having, right? Even for me, I can start out my morning and go into a meeting and I am the boss in that meeting. And then the next hour I am sitting in the meeting and I am the lowest person in the room by far. And so for you, for everybody, paying attention to that and not just carrying the same approach, right? Not always just waiting for somebody else to create it, but to recognize as we're walking in a room, when we have an opportunity to try to make a place safe for somebody else to speak up, we have that opportunity and we can take it. And those small opportunities really matter. You don't have to wait 10 years or 20 years until you're the chair of your department to do it. You can start now in these small ways and they can really matter.
Yeah, both of you spot on. We are almost out of time. So I want to open the floor to both of you and ask if you have any final thoughts that you want to share before we wrap up today's webinar.
But let me just share where Michaela started, which is that we are really excited about the power and the potential of effective teaming and effective leadership to really change the game in this important and hard work of this industry space. So we really do believe mastering these skills and learning how to shape the culture and the climate is mission critical to your ultimate success and probably even joy in this amazingly meaningful industry context.
And I would thank all of you for taking the time today to join us for this. I imagine that not a single one of you on this webinar today has the actual time to invest in sitting through a session like this. So we know that this takes time and effort and skill, and that's really one of the most important things to starting to establish teaming. So thank you for taking the time and taking this seriously. It matters. It really does.
Well, thank you, Amy and Michaela, for sharing your thoughts with us, and thanks to all of you in the audience for your questions. We tried to answer as many as we could, but we hope that you'll take some of the advice that we offered today and implement it in your own teams and organizations as you go back to what you are doing today. But if today wasn't enough, and if you want to learn more, we invite you to apply to be part of the first cohort of Amy and Michaela's latest Harvard online course titled Innovations in Teamwork for Healthcare. If you apply by September 11th, and we encourage you to invite all of your teammates, as the strategies in this course work best when implemented across teams and organizations. If you registered for and attended today's presentation, you'll receive a discount code for the course in your inbox in the next few days, or alternatively, you can find the discount code and link in the chat. Before we go, be sure to check out Amy's new book, The Right Kind of Wrong, which hits shelves next Tuesday, September 5th, and it's available for pre-order. I know I have my copy on pre-order, and also be on the lookout for Michaela's latest research on how teams with steep hierarchies can encourage more dynamic contributions from all their members. Once again, thank you for joining us, and we hope to see you in the course. Goodbye for now, and have a great evening.
Bye, everyone. Thank you for joining, and we look forward to seeing you soon.